Okay, Assalamualaikum. Can you all hear me?
Dengar.
Yes, doctor, we can hear you.
Okay. Sorry for the technical problem. Actually, first of all, I would like to apologize to all of you because our class always need to postpone. And now, because of the COVID problem in the ward, I think other specialists also did mention regarding student in the ward. So actually they try to limit the number of the student came into the ward lah. Because now a lot of COVID positive among our children. So that's why bedside teaching, I think for now cannot be done lah. So maybe for time being we go for long case first lah. Then later on we see how. Is it okay?
Alright.
Okay, so maybe who want to start first?
Kami, Doktor.
Okay. So you are?
Ahmad Nurishman.
Okay.
Okay, so I start Doktor.
Boleh.
Okay. Bismillahirrahmanirrahim. Muhammad Shirley Isaac, a 3 years 5-month-old Malay boy, presented with rash for 1 day. So he was previously well until 2 days ago when he developed fever, which the highest recorded temperature is 38 degrees Celsius in his house. However, it does not associated with any chills and rigors. And it was partially relieved by syrup paracetamol. And then the next day, the boy complained of pain in the mouth. And the mother noticed a multiple ulcer at the soft palate and at the tongue. And then due to that, he have a reduced oral intake because he refused to eat and drink because of the pain.
Okay.
And then because of that also, he had a reduced urine output, which normally he will urinate about 5 to 6 times per day. However, during the fever, he only urinate 2 times per day. However, the color of the urine just a normal yellow color. And then he also have reduced less. He was also less active, where normally he will playing and climbing. However, now he only just lying down and playing with phones. And then also the same day, suddenly he developed sudden rash at bilateral dorsum of the hand and also dorsum of the foot, noticed by the caretaker in the nursery. The mother described the rash as raised, non-vascular, painless, and non-itchy rash. The mother also said there's no rashes noticed on the trunk, abdomen, arm, neck, or the leg. And then he was taken to the clinic and blood was taken and was told there was infection and then was referred to the HDA. For the history, the mother said that he was taken care in the nursery on weekdays and also Saturday. Otherwise, there are no conjunctivitis, no sore throat, no runny nose, no abnormally red-colored tongue, no limb adenopathy, no diarrhea, no vomiting, and no sick contact with other children with similar presentation at the nursery or in the house. And then no travel history, no insect bite, no shortness of breath, and also no cough. And then for the past medical history, it is
Sorry.
okay.
So basically, the main problem is fever, rash, ulcer, and reduced oral intake. Okay. I think for the introduction, maybe instead of you say I'm presenting Muhammad Adam, maybe you can make it more interesting, like you say. So today or before, if today lah. So maybe you can say, I have opportunity to interview Puan Ahmad, mother to adik ni nama apa?
Shirley Isaac.
Shirley Isaac, who is 3 years old. So he presented to us. So actually the main reason this child came to the hospital because of the fever or because of the rash?
Because of the rash.
So your main presenting complaint apa tadi? Rash ya?
Rash for 1 day.
Rash. So you katalah initially presented with rash for how long? And then instead of, but the way you present tadi macam chronological, kan? Sometimes kalau to make it interesting, we have to analyze what the mother say lah. Rather than you go, okay, day 1 fever, and then suddenly tomorrow ada rash. So maybe you make it simple, you just kata because of the main presenting complaint is rash. But you say just now, you just the first two you explain regarding the fever, right? And then the next day you say, oh, suddenly ada rash. So why not you change it? You mention about the rash first, because that brought the child to the hospital. So maybe you explain about the rash. Noted the rash 2 days, 1 day prior to admission, and then you describe the rash to started where, like you mentioned earlier lah. Started where, and then the characteristic of the rash. So like you mentioned lah, itchy, papular, redness, erythematous, and then you mentioned regarding the associated problem. So patient initially came to rash, you explain regarding the detail regarding the rash, and then this patient also have associated problems such as fever. So this fever occur 2 days prior to admission. And then what type of fever? Is high grade fever or low grade fever? Rather than you kata documented temperature. Documented temperature tu later on lah usually kita akan mention. So better you mention regarding the fever punya fever type tu, or characteristic dulu. Fever tu what type of fever? Fever the whole day fever high grade in the morning, and then at night, because each characteristic of fever representing each disease. Dengue, like dengue type of fever dia lain, malaria lain. So at least sebab the undergrad you need to give a lot of differential diagnosis, right? And then need to rule out other differential diagnosis. So that's why each symptom you need to elaborate more. Not just, for example, patient complain of cough, chesty in nature. So and then you leave it like that, cannot lah. So cough, for example, cough. So kena explain more lah regarding cough. Even fever pun, you kena explain more regarding fever, characteristic, what relieve the fever, and then did mother give tepid sponging, regular PCM, and then PCM also you need to ask how much, and then where the mother get the medication. So fever. So symptom lain pun sama lah. Fever, apa nama tadi, reduce oral intake. Okay lah, reduce oral intake, you did mention previously dia minum berapa kan. And then ada reduce in urine output ke? Ada?
Ada.
And then kalau ikutlah, kalau you pakai pampers, you beritahu lah. Tak ada beritahu lah, change pampers.
Malam je pakai pampers, yang dia tak pakai pampers.
Okay lah. So each symptom tu, and then dia nak presenting ni sometimes tu ada je style cerita je positive finding, and then later on tu baru cerita negative finding. So selalunya biasa kalau aku cerita positive finding dululah, and then later on baru negative finding. Macam you kata lah, there is no sick contact, no history of travelling, no history of water tracking, no rats at home, and then water source lah. But sometimes fever, ada rash, sometimes tu boleh dapat daripada lain lah. Lepto pun boleh datang dengan fever dengan rash. Salmonella boleh datang juga fever dengan rash. Atypical infection pun boleh datang dengan fever dengan rash. So you beritahu negative finding lah. So you rule out other cause yang boleh think of. So but fever ni, even fever pun banyak differential diagnosis, right? Tapi but we need to tailor with our common disease. our community disease lah, like salmonella, lepto, dengue. So you need to also mention there is no the dengue prone area, there is no recent fogging. Lepas tu barulah you bagi tahu mother seek treatment. Rather than tadi you mention mother seek treatment earlier kan, and then later on baru you kata there is no semua kan. So yang tu bila kita dah present all the positive and negative finding, later on barulah you beritahu what the mother do. So mother seek treatment on day 2 of illness, and went to GP, and then was given or was prescribed antibiotic ke PCM. However, symptom not improving, so that's why mother brought a child to the hospital, and then full stop. And then baru you go to past medical history. But sometimes tu ialah kalau macam tak tahu macam too short dia punya, you describe each symptom tu, tak tahulah, takut lah kita miss ada differential diagnosis, right? So bila dah you dah positif, negatif, and then later on you list all the differential diagnosis, and then barulah you dapat the actual diagnosis after you examine the child, kan? Okay lah. So past medical. This one rash, the other rash tu kat where?
Only at the dorsum of the bilateral hand and dorsum of the foot, and also ulcer.
HFMD lah ini. Hand foot mouth disease Okay. So past medical.
Okay, past medical history. This is his second hospitalization. The first one when he was.
Satu lagi, now COVID lah. You need to rule out COVID. You did mention COVID.
Oh, tak ada pula.
Sebab now patient boleh datang kan, yang kita now tengah bising pasal MIC, long COVID. So MIC pun boleh datang macam ni. Fever, tapi tak adalah ulcer lah. Soalnya fever and rash. And then sometimes tu dia adalah palpitation, myocarditis, datang dengan hypovolemic shock. Tapi you kena mention lah, now COVID ni even semua komplain pun kita akan relate to the COVID lah. So,
Doctor, MIC stands for?
Multi-system inflammatory syndrome in children, MISC. So now all are talking about, now we know our children 5 to 11 years old advised for COVID-19 vaccine, right? Started about 2 weeks ago. So now we propose them or encourage the mother to bring their children to the hospital for vaccination, because we want to prevent MISC and long COVID. Because we know children in terms of COVID, their symptom is mild, but we worry after 4 to 6 weeks after after children who already have COVID before, we can get MISC and long COVID, because they can with hypocardiogenic shock. Dia akan dapat rash, myocarditis, neurological encephalitis, can get encephalitis, abdominal pain, septic ileus. So sometimes to patient, if not treated earlier, patient even we also have 2 or 3 patients previously with MISC, and one passed away lah, and the other 2 to recover. So that's why we need to ask about the COVID lah. But now fever, even fever rash, patient kena ask regarding any contact with COVID-19 or previously have positive COVID. Okay.
This is his second hospitalization. The first one when he was 8 months old, come with rapid breathing, warded for 3 days, and was given a nebulizer and also antibiotics. And then the mother denied he had any allergy to foods and also drugs. For the past birth history, Alternately, the mother had gestational diabetes mellitus and was on diet. And intrapartum, the boy was born term via spontaneous fetus delivery with vacuum assisted delivery due to prolonged labor with a birth weight of 2.8 kilogram. And postnatally, he had prolonged neonatal jaundice for 19 days and on phototherapy for 3 days in NICU. For the past feeding history, he was breastfed exclusively for 6 months, and then he started weaning at 6 months old with porridge and also carrot. Now, breakfast he ate half nasi lemak ayam, and lunch he ate half of nasi lemak with fruits, and dinner also half of nasi belau with fruits, together with formula milk 2 times per day with 2 ounce, morning and night. And the mother practiced a good bottle hygiene. And for the past immunization history, the boy
Regarding the anthropometry tu, did you chart in the growth chart?
Yes, yes.
So you mentioned earlier.
Belum lagi.
Oh, you mentioned that one you will mention in the physical examination.
Growth growth history.
Oh, growth history. Okay. Okay. Continue.
In the past immunization history, he followed the national immunization program, and the last immunization is during 18 months old, with TTFP, IPV, hepatitis B, and HIV immunization. And then there is no complication to that immunization. And for the growth history, his current weight is 12.5 kilogram, around 10 to 25th percentile, and with 98 centimeter in a 50 centile. And the BMI is 13, less than the first centile. And then the developmental history, the development was up to his age, where now he can goes upstairs, ride tricycles, and also kick balls, and he can draw a man, and can give his full name, his age, and also names to colors. And then he can independently eat and sharing toys with his friends. And then for the past family history, he is the first out of 2 siblings, and then his father is 28 years old and his mother is 27 years old. All are healthy. And then for the past social history, he lived in Ayapute together with his family, and his father is a lorry driver and his mother is a clerk, and income about 3,500 ringgit per month. And then he now during his father and mother working, he will stay in the nursery at Tasca Almoner during weekdays and also Saturday, because only on Sunday his parents are free. And then for the physical examination, he was conscious and alert and also active, seeing him playing with the bone and can run. And then he was not in tachypnea or not in respiratory stress, and also he was not looking lethargic. However, he does mention that he had pain on his mouth. And then there was cannula attached on his left hand with no active infusion. And then on examination, there's no conjunctival pallor, no jaundice, and then not and then no pallor with good oral hygiene. And then there's multiple ulcer noted at the inferior part of the tongue, soft palate, and also throat. And then there's no limb adenopathy, and the hydration status was also good. For the vital sign, the temperature is 37 febrile, and pulse rate about 138, slightly high. And then the respiratory rate is 30 breath per minute, And then the blood pressure is 107/65 with normotensive. And then also for the examination, noted there's macular rash at the bilateral dorsum of the hand and also dorsum of the foot. And then there's one like a few rash around his mouth. Other than that, the examination is unremarkable. If for the summary,
Okay.
summary, Muhammad Shali Isaac, 3 years old, 5 months, 3 years, 5 month old Malay boy, presented with rash for 1 day, and also he had it was associated with fever 2 days duration, and also reduced oral intake, and also less active for 1 day duration.
Okay.
And for the examination, there's macular rash at the bilateral hand, bilateral dorsum of the hand and the foot, and also multiple ulcer on the inside the mouth.
Other system unremarkable.
Other system was unremarkable.
Okay. So what is your from the history and physical examination? So what is your diagnosis?
My diagnosis
And how do you manage this patient?
My diagnosis is hand foot mouth disease. Because the eruption of the rashes just around the dorsum of the hand and foot, and also in the mouth.
Okay, so patient also have hepangina. So we call it hepangina, right? Mouth ulcer, we call it hepangina. So patient have hepangina with rashes at the dorsum and the hand and foot lah. So this one may be straightforward lah. Straightforward. So do you think is there any differential diagnosis? Fever, rash, and other ulcer.
Maybe herpes simplex infection.
Okay, but herpes simplex typically where? Where do you see the rash?
The rash can also note at the trunk.
Herpes,
at the hand, at the leg.
Sure, herpes. Herpes usually around the mouth, right? Around the mouth. And it depends lah. Herpes type 1, type 2. Around the mouth and around the genital area, yes. So you did mention earlier regarding there is no lymphadenopathy. So you want to rule out what actually?
Kawasaki.
So other differential diagnosis can be Kawasaki lah. Maybe a atypical one lah. But usually Kawasaki did not come with other ulcer, but it can come with fever and rash. So fever and rash need to route Kawasaki. But sometimes patient can atypical or incomplete Kawasaki lah. Did not need to fulfill all the 4 criteria. But fever must more than 5 days. And then we look for other criteria for the Kawasaki. Other than that, dengue lah. You need to rule out dengue, even low in the list, but still possible. But the rash is not typical for dengue lah. That's why we rule out dengue. But if fever, rash, dengue common here, dengue, Kawasaki, and foot mouth disease, and then COVID lah last for now. So how do you manage this patient?
In terms of the investigation.
Okay.
Usually for HFMD is a clinical diagnosis.
Okay.
However, we can do throat swab for basic. If there's vesicle, we can do the culture of the vesicle fluid.
So what do you expect to find in the swab or any culture that you take?
In HFMD, might found a
What is the common cause? Yes, Kawasaki and
enterovirus.
enterovirus lah. So usually both lah. Okay. Usually we don't do lah because hand, foot, mouth disease is we call it self-limiting. By the time 7 to 10 days, patient already recover. So sometimes to just the treatment is just symptomatic treatment. Patient have fever, give paracetamol. Oral ulcer, you provide the oral aid. So oral aid, which one you choose for this 3 years old?
Eight.
Oral aid, dia ada banyak kan, oral paste, spray. Usually we advise for mother to buy a spray lah, easier and more effective to the children, because you know the ulcer is very painful. So if we use oral paste, child will struggle and the medication cannot give properly. So better we go for spray, and then it's more better effective compared to oral aid. And then usually the typical Kawasaki, sometimes it can initially rash to like a red spot rash, flat, macular rash, and then later on 1 to 2 days it can become a blister. Sometimes foot mouth disease can come with blister lah. Satu lagi kalau datang dengan blister macam tu, kena rule out chickenpox also lah. Fever and chickenpox. But the difference between chickenpox and hand foot mouth disease, the characteristic of the rash. So what do you advise to the mother? If mother have hand foot mouth disease, what do you advise?
Advice for the mother for hygiene.
Why?
Because of it can spread.
So hand foot mouth disease is a transmissible disease. So it transmit or can transmit via the fluid, from saliva, mucus, even from the rashes itself. If rashes become blister, it can transmit. So we advise them. That's why if mother working in government servant, they are opted to take leave for about 5 days to take care of their children if patient have hand foot mouth disease. So stay at home, maintain good hand hygiene, and then I think that's all lah. So for hand foot mouth disease, it's just straightforward lah, more to symptomatic, and then maintain hand hygiene. Okay lah.
Doctor, basically, Ahmed, Anurishman mentioned that basically in the nursery there's nobody in contact with HFMD. So is they I mean there might be a source of the HFMD, right? We need to find out where it is, because I think
but sure, true. So sometimes actually usually in crowded area, but maybe we need to ask more. Sometimes maybe this child, I don't know lah, maybe because enterovirus is enterovirus or Kawasaki virus, patient we can get from the crowded area. So we need to ask whether is there any history go to mall or night market, and then maybe later on you try to ask. For now, during patient have symptom, there is no child in the caretaker nursery have symptom, right? If you see again, but now patient already discharged, right? Maybe later on we cannot say. Maybe other children also have been infected by this HFMD. So not sure lah when, but we need to ask lah.
So it doesn't have to be that it must be a skin contact. That's not necessarily true.
No, not necessary. It's not necessary. It's not a skin to skin contact. It's a fluid contact. Even patient have cough or any mucus or saliva. So if any of the children have contact with that, patient will have a HFMD. It's not necessarily a skin to skin contact because it's a fluid. Macam like COVID lah kan. No need to skin to skin. Okay. And any other question?
Doctor, if in the ward, the patient does not need to isolate.
Supposedly need to isolate. So this patient was put in the open ward, right? Put in isolation.
Because of COVID, I think.
Oh, okay. So where did they put this patient?
Just
in the open ward.
the open ward.
Subacute.
Yeah, subacute.
In the at the middle or in the ujung-ujung ni letak at the corner.
In the middle.
So suppose they need to put in the isolation, but I don't know how lah. Now we don't have any isolation because already occupied with COVID patient.
Yeah,
so,
and I think during that time there was 2 patients that has neutropenic sepsis in the isolation already. 2 patients there.
Yeah. So because of what we can do, put patient in the corner and then put the screen, and then we need to put beside the bed too, we need to put the sign, and then we need to put the hand rub, so other patient may aware regarding that patient supposedly lah. But I don't know why this patient put in the middle of the ward. Okay. Any other question?
The contents of the oral aid are more of analgesia, doctor, or are more of basically antiseptic? But yeah.
Now there are many order aid combined. So basically for order aid that we have, and usually I like to use or offer the parent to buy ginger gel. Brand ginger gel. Haven't heard about it? Ginger gel. Because ginger gel have a spray one. So ginger gel, it contain, if I'm not mistaken, hyaluronic acid. So it can soften the inflamed area, and also contain a bit of anesthetic. So even without oral aid, the lesion can recover by itself. But to fasten, because if you have oral aid, child cannot eat. So that's why most of them presented to hospital because of the poor oral intake, because of the ulcer. So that's why we give oral aid to the child so that they can eat. So we ask mother to spray before eat, so that they can eat properly and can lessen the pain. Okay. So is there any case presentation? Other case?
Me, Dr. Aiman.
So you want to present?
Yes.
Okay. Okay, go ahead.
Okay, so I have an opportunity to play the father of Muhammad Affan, a 6-year-old Malay boy presented with to us with
Sorry, how old the child? Sorry.
6-year-old Malay boy.
Okay.
6-year-old Malay boy presented to us with shortness of breath for 1 day prior to admission.
Okay.
He was apparently well until 1 day prior to admission. He suddenly developed shortness of breath in the morning.
Okay.
The father said that he was playing at that time, where suddenly he developed shortness of breath. With the mother witnessing, he was getting for air. Then his father straight away took him to private clinic, where at the clinic he was given nap for one time, and it already resolved. And the doctor at the GP advised the father to come back to any clinic if the symptoms come back. And then at night, the symptoms of shortness of breath developed back, which forces the father to brought him to the clinic, where at the clinic he was given 2 times nap, but still didn't resolve, and later was referred from the clinic to HTE. Upon further questioning, his father said that he had developed cough first before the onset of the SOB for 3 days prior to admission. The cough was described as to be chesty cough. However, the father did notice of the color of the sputum. It was partially relieved by antitussive medication. The father also noticed there is a presence of subcostal recession during the SOB symptoms occur. The father also claimed that he had seek contact with his sibling, where his sister had coughed before him. However, the father denied the child of having any fever, any bluish discoloration during the SOB symptoms, runny nose, denied of having any failure symptom such as paroxysmal nocturnal dyspnea and also octopnea, any hemoptysis, any noisy breathing. And he also denied of having any sick contact with COVID-19 patients.
So that's all regarding presenting.
Yeah.
Okay. So like I mentioned earlier, so during when we want to present the presenting complaint, in the first part too, okay, quite good. You mentioned regarding presenting complaint, SOB, started when, associated with what. But when you start to mention, and then after that, father brought to the KK, and then resolve, come again, it's like a storytelling or chronological. So sometimes we cannot take fully what the parents said. We have to analyze. We need to analyze. We are not storytelling. The way you present is like a storytelling. So, like I mentioned earlier, you need to put all the symptom or complaint that patient have. Because just now you mentioned patient have SOB, and then my father brought to ED, and then give nap, go back, symptom worse, come again. And then barulah you kata this one or associated with cough runny nose. It became anti-climax tau, cerita tu. Kan, cerita tu last sekali, dah tahu dah, dia dah pergi klinik dah, okay, dah macam dah, okay, orang pun tak nak dengar dah. So, because you undergrad, kalau postgrad, dia punya presentation lain. Postgrad presentation lagilah, you tak boleh nak mention. Kalau you mention pasal patient datang cough runny nose, consultant you tak nak dengar dah. you punya ni. You kena dah analyse lah what the patient have. And then you dah tahu dah. Kalau undergrad, you kena present satu-satu. And then present satu-satu tu maksudnya you cannot lah macam storytelling. Maksudnya father buka kereta, masuk kereta, duduk. Lepas tu ayah buka enjin, tekan minyak naik, pergi klinik macam tu. You cannot present like that. So that's why you need to list all the presenting complaint. So the chief presenting complaint is SOB. Okay, you mentioned about SOB. SOB, shortness of breath started when, morning, worsen when, associated with what? Chest indrawing, noisy breathing like you mentioned earlier lah. Kalau ada lah noisy breathing, tachypnea, ada chest indrawing. And then prior to that, I think lah, this symptom, this chief complaint ke preceded with fever, cough, runny nose. Sama lah, fever pun sama. You kena mention detail regarding fever. Fever macam mana, what type of fever, what the parent do to relieve the fever. Therapy sponging, give PCM. Cough pun sama. Type of cough, chesty cough, prolonged bout of cough, associated with associated with cyanosis or facial congestion. Is there any post-tarsal vomiting? So apa lagi patient ni ada? SOB, fever, cough, runny nose ya? Apa ni? Main complaint dia apa tadi?
Patient ni ada SOB dengan cough, chesty nature. However, dia tak ada fever, tak ada noisy breathing.
Okay. Kalau tak ada tu, just bagi tahu. Bagi tahu letter lah. Sometimes tu noisy breathing yang related to the SOB, you boleh mention earlier. It's not necessary you nak simpan negative finding tu at the end lah. Sebab at the end tu dia dah macam bercampur dengan simptom yang lain. Kalau macam tadi, kalau SOB tu you boleh mention there is no noisy, dia ada SOB ataupun rapid breathing lah. Rapid breathing with chest indrawing. However, there is no noisy breathing. Such as, kalau you nak boleh mention whistling sound ke, grunting ke, stridor ke, you boleh mention earlier. So at least examiner dah tahu, you dah already out. Macam patient severe respiratory distress boleh datang grunting. You dah already out stridor. Maksudnya stridor usually upper airway. Macam pertussis ataupun patient boleh datang dengan epiglottitis, croup kan. You dah do out. So examiner pun dah tahu, okay, ini dia dah do out. So SOB dia tu bila you dengar tu shortness of breath tu, because shortness of breath it can be caused by upper or lower airway, right? So kalau you dah macam upper airway, macam you dah mention stridor, there is no stridor, there is no shortness of voice, there is no grunting, okay, examiner dah tahu, okay, you already out the upper airway. So this case maybe lower airway lah, like pneumonia, bronchiolitis. Kalau ada onset of shortness of breath, mungkin foreign body expiration. You mentioned earlier. So sama cerita dia. So you kena rewrite balik and then you cuba susun symptom wise dulu. And then pasal you pergi GP apa semua tu you boleh mention, but try to mention at the end of your presentation after you already mention the positive and negative finding. Kan? Boleh kan? So you all rasa macam mana? Other lecturer how so macam mana dia orang ajar tu? You all presenting complaint.
Kalau macam Datuk, dia nak kronologi.
Okay, maksud saya kronologi tu bukanlah kronologi. Kronologi memang kena ada. Itu tak dinafikan. Cuma mungkin the way you write and the way you try to explain to the examiner yang buatkan dia jadi lain. Kronologi tu still ada, memang kena ada. Buat sometimes tu kita tak tahu kan, day 1 apa, day 2 kita nak tahu. Kronologi tu mesti ada, cuma macam mana you buat tu. Masuk kronologi tu adalah bagi akulah, you cerita dulu apa yang patient ada dulu. And then lah baru you kata. Lepas ada you cerita semua, okay. So this patient seek treatment or seek medical attention on day 2 of illness. At that time, patient only have shortness of breath. So it was treated. You tak kalau you simplify pun boleh sebenarnya. You tak perlu cakap. You just katalah seek treatment on day 2 of illness and then was given antibiotic. 2 dose 2 times per day lah contoh. So kita boleh tahu mungkin pasien ni bagi ampicillin. Bukan ampicillin, amoxicillin. Ataupun OD dose, mungkin pasien ni bagi azithromycin. So boleh mention macam tu, just give you just summarize je lah. Went to ED, went to GP, was treated and given antibiotic and antipyretic. However, the symptom not improve. You tak payah cakap dia balik rumah and then at night the symptom worsen again. Tak tahulah kalau Datuk nak macam tu ke? Datuk nak ke beritahu balik, lepas tu duduk malam, lepas tu nafas laju and then pergi balik. Maybe you can simplify lah. Like I mentioned earlier lah. Seek treatment on day 1, given antibiotic. Parents child compliant to medication. However, the symptoms not improve. So the fever still spiking temperature. And then mother brought child to the ED hospital. On the next day ke at night ke, just that's it lah. So orang tahulah, okay dia dah seek treatment. Sometimes tu yelah, sometimes tu kita pun nak tahu apa yang dah buat kan, dah demam 2-3 hari takkan tak bawa apa-apa kan. Sebab sometimes kita nak tahu tu sebab kalau patient datang if patient came with pneumonia and already took the medication, so the diagnosis also differ lah. Maybe you can put partially treated or partially treated pneumonia or partially treated other things lah, other yang lain. So for me lah, I tak tahulah. Kalau tak tahulah, kalau ada lecturer macam mana the way dia susun the presenting, dia arrange the presenting complaint tu. You all rasa macam mana?
Macam yang day 1, day 2 rasa cuma macam simplified.
Macam mana? Day 1, day 2. Oh, kita siapa? Datuk lah.
Datuk mainly dia nak kronologi lah.
Okay.
Awal-awal dia tu kan macam mana.
Okay, tapi okay, kalau contoh in this case lah, even kronologi pun, waktu dia shortness of breath tu dia tak ada cough, tak ada runny nose.
Ada. Dia cough dulu datang.
So that's why, sebab tadi you present kan, shortness of breath, went to GP kan, right?
Iya.
So kalau macam ayat yang itulah yang I try to yang saya biasa buat lah. Sebab kita tak lari pun daripada kronologi, right? Cuma kita just beritahu simptom dia. And then kalau nak nampak kronologi, you boleh beritahu lah patient presented with shortness of breath 2 days prior to admission. And then you cerita shortness of breath, this symptom associated with. So orang dah tahu dah shortness of breath tu waktu yang sama dengan cough dengan runny nose kan. And then barulah you beritahu apa yang dia buat. Day 1, maksudnya pergi GP apa semua tu. Kecuali simptom tu datang, simptom tu came macam staggered. Right. First day 2 of illness only have fever. And then later on, fever resolve, cough and runny nose. And then cough, runny nose persist, ada shortness of breath later on. Boleh lah. Ataupun the other way round lah. Shortness of breath 1 day prior to admission, cough 2 days prior to admission, fever 3 days prior to admission start. Boleh juga macam tu. Kecuali kalau lah kes tu lama, maksudnya dah 1 week. 1 week dah unwell. Mungkin you boleh mention lah day 2 of illness went to GP, symptom not improve. Day 3 go again to GP. You boleh mention macam tu. Tapi yang penting supaya tak serabut lah bagi aku, sebab kita nak kumpulkan the presenting complaint dalam satu ayat ataupun maksudnya kita mention dulu simptom dia, barulah kita nak cerita dia pergi mana. Sebab nanti tak tahulah, bagi aku dia jadi serabut bila dah pergi GP, lepas tu dah cerita pasal simptom dia lagi. So macam tak in order lah. You faham tak apa yang nak cuba cakap? Faham lah. So depend lah cara macam mana. Tapi I think yang penting examiner nak tahu what you thinking lah. And then apa differential diagnosis yang dah you do out. Cuma macam tadi tu I tak tahulah. Dia macam tak tahulah, tak best lah kot. So, tapi okay dah, you did mention awal semua tu, in each complaint tu you did mention, you did describe. Cuma how to susun tu je lah, how to arrange to make it sound more, apa panggil, sedap lagi lah kot. Okay. Okay, then. Proceed.
Okay. So for the past medical history, this is no medical illness. This is first time being hospitalized. And otherwise, for the surgical and he also doesn't have any drug allergy.
Okay.
As for the feeding and nutrition, he eats 3 times per day, where he eats breakfast, lunch, and dinner. Where during breakfast he eats nasi goreng or fried rice. During lunch he eats rice with vegetable, chicken, and fish. And for the dinner he usually eats rice also with chicken and vegetables. He is not a picky eater. He was breastfed up until 2 years of age, and there's a snacking between the meals where usually he eat keropok or goreng pisang.
Okay.
For the developmental history, his developmental history is normal up to the age. At school, he had many friends where he always play bicycle in the evening with his friend and also his siblings. And his academic achievement is also good. For the birth history, he was born term at 38 weeks period of gestation via spontaneous vertex delivery with postnatally with uneventful, and also during the pregnancy is also uneventful. For the family history, his father age 37 years old and his mother is age 7 years old. He has 3 siblings. He is the second sibling out of the three siblings, where all are healthy. However, the father had diabetes mellitus, and also his father is also a heavy smoker, where he smoked 1 pack per day. For the social history, he lived in Sungai Soy, 1-story house, semi-D, lived with 5 family members together. The father works as penolong accountant in Wisma Darul Makmur, while the mother works as a teacher at SMK Tanjung Lumpur. And his total monthly income together is around 10k ringgit Malaysian.
Sorry, one more thing. In the presenting complaint just now, did you mention regarding asthma?
Asthma, no. Family history of asthma, atopy tadi.
Okay. So the other thing I forgot to mention regarding asthma lah, because this patient given nap, right?
Yeah, that.
So you have to ask regarding asthma also lah. You need to ask regarding the interval symptom, that time symptom, when is the first nap, and then is this recurrent nap, what trigger, so that we did not miss asthma, ataupun this patient have underlying multi-trigger wheeze or episodic wheeze. So you did mention regarding the atopy, right? Eczema, allergic rhinitis. Is there any family history of asthma?
No, however, the mother had allergic rhinitis.
Okay. Okay.
That's all.
Okay. Sometime, how old the child again?
6-year-old.
So in 6 years old, asthma, I think asthma, you need to ask regarding asthma. Because sometimes, this patient asthma or pneumonia? You think
Pneumonia.
Pneumonia.
With bronchospasm.
Actually, for diagnosis, pneumonia bronchospasm, it's not a diagnosis. Bronchospasm tu dia ambil dari mana?
Dia, saya fikir sebab dia nap 2 kali. Nap sekali tu dia okey.
Maksud saya, where do you get the term bronchospasm tu?
Selalu dekat BST lah nampak.
BST You all mana boleh tengok BST kan?
Lepas dah klik tu tengok lah sikit. Sama ada betul tak.
So actually salah lah. Salah. Nanti I kena beritahu ni. Actually there is no diagnosis of pneumonia. Even in ICD-10, you tahu kan ICD-10?
ICD-10.
You tahu ICD-10 tu apa? ICD-10 ni adalah kita panggil apa? International Classification of Disease. So any diagnosis yang apa-apalah diagnosis, kita akan based on ICD-10. Dia ada nombor-nombor dia lah. Okay. Asma, apa nombor dia? P0.5 apa semualah. Yang kita classified. Maksudnya kita classified with according to the number. So dalam ICD-10 ni, diagnosis yang kita proven lah. Macam pneumonia bronchospasm. Bronchospasm tu is just a description. It's not a diagnosis. The description of the disease. So actually it's wrong to put the diagnosis pneumonia bronchospasm. Sebab dia pelik lah. But that, actually kalau nak letak, dia letak as pneumonia je. Sama ada mild, moderate, severe pneumonia ataupun bronchopneumonia, ataupun kalau X-ray too worse, put lobar pneumonia. Even kita nak kata viral pneumonia ke apa ke, susah in the first counter with the patient ataupun first impression diagnosis kita. Sometimes we can differentiate whether it's bacteria or viral, but actually we need to have the evidence to say whether it's viral or bacteria based on culture that we took from the patient. Nasal swab ke, aspirate from the kita nasopharyngeal aspirate swab, kita send untuk check for viruses ataupun for bacteria. Then barulah the final diagnosis before the patient discharge, barulah kita put the final diagnosis lah based on the investigation that we gather. So in the first place, you can put only bronchopneumonia or lobar pneumonia, and there is no such thing on pneumonia with bronchospasm. But lately, memang bukan lately lah, for the past few years ni, I pun tak faham datang daripada bronchospasm tu. Usually ED lah, you put bronchospasm. But sometimes macam now ni, even bronchospasm, dia jadi dah keliru lah sekarang untuk pneumonia. Even asma pun, dia ada bronchospasm. Pneumonia pun ada bronchospasm. So jadi pelik. Basically, kalau you baca, you tengok pathophysio or how macam pneumonia develop, suppose dia tak boleh dapat bronchospasm pun. Sebab dia macam tu pathway yang berbeza, tu patologi yang berbeza. Asma lain. Asma lebih kepada dia obstruktif lah. Pneumonia more to restrictive lung. So kalau obstruktif, that's why you dengar capitation, you dengar waktu bila? Kalau auscultation tu. Inspiratory kan?
Inspiratory.
Kalau asma, dia dengar waktu expiratory. Sebab asma ni macam, dia act like both valve effect. Air go in, but cannot go out. That's why you dengar whistling sound during the expiration phase. And capitation tu is more of the inflammation and fluid. That's why you dengar coarse capitation ataupun fine capitation in the pulmonary edema patient lah. Kalau pneumonia ke bronchiectasis dia akan dengar cough sebab lung dia wet. And the pathophysio is different. And then dia orang letak, tak tahulah dia orang macam mana dengar rongkai. Semua nak bagi neck. So actually for me, it's wrong to give salbutamol ke neck in pneumonia patient. Tapi sometimes yelah sebab kita tak boleh nak deny because during examination dia dengar rongkai. Okay lah, fine rongkai. So give salbutamol. So basically pneumonia no need rongkai, no need salbutamol. Aku dah melarut dah. So no need salbutamol. So nanti kalau you belajar nanti kena ni lah, you tengok balik lah. Tapi pneumonia tak ada bronchospasm Walaupun kita rasa okey lah dengar rongkai. Actually saya tak tahulah, itu bukan rongkai kot semua tu Tak tahulah. Tapi ada je. Bukan tak ada pneumonia datang dengan bronchospasm yang teruk. Dia pneumonia, even dia tak ada family history of asthma, tak ada apa, tapi chest x-ray features of pneumonia. Tapi kalau macam rongkai teruk macam ni, memang sometimes tu we can diagnose newly diagnosed asthma. Kalau cukup kriteria lah. Strong family history, walaupun dia first nap, tapi dia behave like asthma lah. Maksudnya bagi salbutamol respon. Sometimes tu even you bagi, kalau pneumonia, even you bagi banyak mana pun tak respon, tu bukan bronchospasm lah. Maksudnya pneumonia itself lah. Pneumonia pun boleh datang reduced breath sound. Sometimes tu kat ED turun bawah, dia orang dengar rongkai, reduced breath sound. So try bagi salbutamol. Kata lepas tu tak improve. Tapi still ada dengar lagi. So maksudnya itu bukan bronchospasm. You bagi banyak mana pun, salbutamol cannot improve the symptom. Sebab bukan itu treatment dia. So kena hati-hati sikit lah. Kalau tak, kita diagnosis pneumonia sahaja lah. Apa nak cakap dia? Okay lah, proceed lah.
So on physical examination, the general examination, the patient was lying comfortably in prop-up position. He was being and alert and conscious with the surrounding. His body appetite is slightly overweight with no dysmorphic features. For the anthropometric, his weight is around 56 and his height is around 254. His BMI is around the category of overweight. For the vitals,
Okay, vital sign.
for the vital sign, for the respiratory rate, is normal where around 22 breaths per minute, and also for the heart rate is around 85 beats per minute.
Kalau tu
Kalau
you present, maksudnya you tak perlu sebut around lah kot. Masuk around tu maksudnya you just show you are not sure. Around. You just mention je lah. Tak tahu. Tapi kalau you all punya you present masa present physical examination ni, you akan present satu-satu ke you present yang positive finding?
sepatutnya positive finding lah.
Positive finding lah. Okay.
Tapi patient ni normal.
Normal lah. Normal. Okay. Normal kenapa masuk ward lah?
Ni dah di 5.
Dah okey lah. Okey lah. Normal. Okay. So you kena letak disclaimer. So I clerk this patient on day 5 of illness. Patient was preparing to go home lah. Okay, kalau you mesti ballot folder kan, BST kan. So what is the examination of physical finding during during admission?
Dia ada subcostal recession.
Okay. So kalau lung finding, you need to you present regarding the lung first lah. On the examination, patient was comfortable lah kan, ataupun patient was not patient was in respiratory distress, as evident by patient noted tachypnea with RR of 48, and there is also subcostal and intercostal recession, and patient was attached to the nasal prong. And kalau ada SpO2 kat situ, you mention lah, okay, attached to the nasal prong, and I can see the saturation of the patient is 98%. For lung examination, the chest wall moves symmetrically with each respiration, and there is no asymmetrical movement, there is no chest deformity, such as pectus excavatum, pectus canarinatum. There is no surgical scarring. And for the palpation, there is normal resonant ke ikut lah, increased resonant ke hyperresonant. And then for auscultation, the breath sound is equal bilaterally, and I can hear the capitation, fine capitation. And then you can mention lah whether it's vesicular ke bronchial breath sound. So what are the difference between what is the normal sound or what is the normal breath sound?
Normal breath sound usually a vesicular breath sound.
So how do you differentiate whether it's vesicular or bronchial breathing?
Yang bronchial selalu dia macam kat belah-belah sini, belah-belah central bunyi dia.
Belah-belah center. Maksudnya location, site ya? Ya ke?
Tak, bunyi dia macam dekat
bunyi apa? Maksudnya bila you auscultate tu, you place the diaphragm tu, dia ada spesifik tempat ke?
Tak ada.
Kalau central dia bronchial, kalau tepi sikit, belakang sikit dia jadi apa? Vesicular. Macam mana you nak differentiate? Kalau you kata vesicular tu normal breath sound, right?
Ya.
So bronchial tu tak normal lah kan?
Ya.
Bronchial breathing. So macam mana you nak tahu itu adalah vesicular or bronchial breathing?
Vesicular tu inspiratory is longer than expiratory.
So dia ada gap ke dia tak ada gap?
Dia tak ada gap.
There is no pause lah kita katakan. There is no pause between inspire dengan expire. So that's normal. Kalau bronchial breathing,
Dia ada gap, lepas tu expiratory punya time tu might be sama dengan inspiratory.
so the duration, the phase tu between inspire dengan expire tu the same, and there is no gap between. Kalau you dengar tu, kalau kita dengar yang kita punya, kita akan dengar tarik nafas, and then ada pause in between, and the expire tu shorter lah kan, inspire tu longer. Kalau bronchial breathing dia sama je, and there is no pause. So they indicate something lah. Kalau you mention there is reduced breath sound over the right side with bronchial breathing, so examiner dah tahu, okay, you are talking about consolidation, fibrosis, and then you can mention lah additional sound, fine capitation. Kalau you mention fine, cause capitation, pneumonia lah. Ataupun you talking about the bronchiectasis. Kalau you kata fine capitation, you talking about pulmonary edema ke alveolitis. Apa entah satu tu. So daripada you jangan just mention the breath sound is equal bilateral, that's it, tak boleh lah. So you kena mention daripada awal lah, you tak boleh kata equal air entry. So term tu salah lah, kalau you cari dalam BST tu term tu salah. Tapi ramai yang tulis lah macam tu lah. Lung equal air entry, dia kena breath sound, equal breath sound. What type of breath sound? Equal breath sound, it is a vesicular breath sound. And then you kena dia point kat situ tak banyak je, breath sound, type of breath sound, whether it's vesicular or bronchial, additional sound cavitation. Dia kena mention lah is fine cavitation ataupun coarse cavitation, atau ada rongkai. Kalau prolonged expiratory phase, beritahu ada prolonged expiratory phase. Sudah, tak ada lah lung finding. Lepas tu CVS, CNS tu just ni lah, kalau tak significant, you all just mention that the other system was unremarkable lah kan. Okay. Next. Okay, dah. Habis dah?
Dah. So diagnosis the patient pneumonia.
Okay. Summary tak ada?
Summary, for the summary, my patient, now 5-year-old labor presented with shunt for 1 day prior to admission. It also associated with chesty cough.
Okay. Summary tu maksudnya you all summary just mention all the
Positive finding
lah.
Yeah.
Okay. And lepas summary baru you mention regarding the diagnosis.
Yes.
Oh, you all sampai summary je lah kan? Diagnosis apa semua tu you akan mention bila? Tak ada lah.
After summary, Doktor.
After summary.
Oh, okay, continue. But sometimes I pun terlupa dah undergrad, tak ingat. Sebab kalau postgrad summary kita tak mention dah benda tu. Kita just kata all this question. So contoh Muhammad Adam, 2 years old Malay boy, was diagnosed to have bronchial asthma, for example, moderate or severe bronchial asthma with underlying intermittent or mild persistent bronchial asthma, currently well and fit for discharge, and there is no and the disease was not affected the child psychological to the family or the parent. Okay, itu kita orang punya summary lah. So kalau undergrad you kena mention all the positive finding kan?
Yeah.
Dengan
History.
PE.
Yes.
Okay. So in summary,
now 5-year-old labor presented with short subject for 1 day prior to admission associated with chesty cough for 3 days prior to admission. As for the physical examination, however, for the physical examination during this time is unremarkable.
Okay lah. Okay. So what is your diagnosis?
So my provisional diagnosis for this patient would be pneumonia. Sebut dulu severity, moderate.
Hello?
No, Doctor. My provisional diagnosis would be pneumonia.
So sorry, you akan beritahu kenapa you kata pneumonia?
Because of the evidence of the point again would be the chesty cough, shortness of breath. However, the consequence would be the patient denied of having any fever, any
Patient datang dengan rapid breathing, right?
Yeah, rapid breathing je.
So maybe you can mention that. So my professional diagnosis for this patient is pneumonia. It's evidenced by from the history this patient have respiratory symptoms such as cough, runny nose, and rapid breathing, supported by physical examination. During presentation, patient noted to have tachypnea, and line finding also consistent with pneumonia, such as there is a cavitation over the right side or reduced entry. And also from the investigation, kita tak masuk pun lagi kan investigation kan. Kalau kita dah mention mungkin you boleh masuklah chest x-ray. Boleh katalah chest x-ray also consistent with pneumonia. Okay, that's it. Tapi saya tak tahulah you all punya kalau diagnosis sebelum ni you all present macam mana? You just mentioned professional
daripada
diagnosis.
history, daripada
That's it,
PE, lepas tu proceed dengan investigation.
Okay lah, sebab kalau you tengok you all tu, you akan letakkan pneumonia, kenapa you sebut pneumonia, right?
Ya.
And then differential diagnosis, kenapa you sebut benda ni, and then apa yang you rasa bukan lah for this patient, because patient did not have this, right?
Yeah.
Okay, so second differential diagnosis.
Second differential diagnosis would be asthma. Because
bronchial asthma.
Yeah, bronchial asthma, because patient so have the respiratory symptom, which SOB, so cough,
and require nap lah kan?
and require nap, where it resolves during the nap.
Okay, resolves. However, the bronchial asthma is less likely in this patient because
there's no history of family history of asthma,
no
no
family history of
atopy,
asthma, no atopy,
allergic symptoms, no eczema.
So is it possible this patient may have asthma in the future?
I think so, possible.
Okay, so you jawab macam tu lah. So it is possible for this patient to have bronchial asthma in this patient. That's why we need to advise the mother or parents to look for sign and symptom of asthma. Most of the time boleh datang macam ni lah. Maybe the first presentation tu memang patient dah ada asthma dah. Tapi at that time tu mungkin mask with pneumonia. And then the symptom tu macam the bronchospasm tu, yang you kata bronchospasm tu pun tak, maksudnya improving after first or second nap. And there is no other family history of asthma, and this also a first first nebulizer. From the history, there is no interval, no daytime, no nighttime, no exercise induced. So at this point, less likely lah patient pneumonia, but it is possible to have this patient may develop asthma later, because age pun dah, kalau datang sekali lagi macam ni, mungkin you tak agak-agak lah tu label dia asthma. Tapi dia kena ada evidence of obstructive symptom lah. Rongkai, by asthma definition pun recurrent cough, chest tightness. Yes. Okay, lagi? Ya, 2 je. Habis dah, tak nak dah.
Kalau TB tak boleh
TB, kenapa you rasa ada TB?
Sebab dia macam breath dengan cough tu, tapi
boleh. Differential diagnosis ni kalau kena satu pun tak apa dah kan.
2-1.
Dah masa aku hello?
Ya. No.
Beritahu doktor tu.
Siapa?
Orang TB.
Hello?
Dia tak nak dah ni.
Dia keluar dia.
Dia tak nak dah. So siapa TB? Kenapa TB?
Sebab dia show of breath, cough. Tapi
cough lah, mainly cough lah, tapi you kena mention lah.
Bukan hemoptysis tadi.
Ya, bukan chronic cough, tak ada panggil apa panggil tu?
Hemoptysis.
Tak ada hemoptysis. Bukan, patient datang loss of weight.
Loss of weight.
Loss of weight, sweating. Dia ada term dia. Tak apalah, saya dah lupa lah. So lagi TB, pneumonia, okay lah, mainly pneumonia, asthma. Bronchiolitis, is it possible bronchiolitis?
Boleh.
Tapi itu bronchiolitis tu macam down the list lah. Sebab?
Age pun dan
sebab dia dah 6 years old. Age group tu dah tak kena dah untuk bronchiolitis. Sometimes bronchiolitis tu in between less than 1 year atau less than 2 years lah. Sometimes 2 years pun berat sangat nak kata dia bronchiolitis. 1 year 6 months below lah. Nak kata dia bronchiolitis. Because bronchiolitis ni most common in the apa panggil, in the early age lah, early age, below 1 year 6 months old. In the protocol 6 years 1 year old. So lagi
Lepas tu kalau foreign body aspiration,
foreign body, cuma
because of
against
short
dia
of breath.
against dia adalah sudden onset lah. Ada sudden onset, and then foreign body dia akan ada apa, stridor lah.
Stridor, lepas tu bluish discoloration.
Yes, stridor or bluish. And satu lagi apa yang color choking related to what? Dia macam foreign body, dia aspirate jugalah. Aspiration pneumonia lah. Apa-apalah. Not necessary foreign body tu kacang ke Lego dia ke mainan dia ke, sometimes tu dia choking susu dia lah, kita kata aspiration pneumonia kan. So boleh dapat juga aspiration pneumonia. So apa lagi differential? Tak ada dah.
Kalau yang group apa sebenarnya tak boleh sebab age dia.
Group selalunya kecil lah, tak tu, and then patient ni dah 6 years old, complete immunization kan. And then tak ada hoarseness, tak ada barking cough, tapi unlikely to hepatitis lah. So even nak mention nak dalam differential pun kita rasa segan.
Sebab age tu
sebab age. Soalnya age tu yang soalnya budak kecil, umur 2-3 bulan, 6 bulan ke bawah lah. Sebab dia tak dapat lagi detect kan. So detect dah 2, 3, 5 baru dapat. Itulah yang point. So okay lah. So after the differential, after diagnosis, investigate lah.
Investigation.
So how do you investigate this patient lah?
So for investigation, first I would like to do the bedside investigation, which be the peak respiratory flow rate.
Apa?
PEFR. Boleh kan 6 tahun?
Okay, you know about PFR. Kenapa you know about peak respiratory flow rate? Kenapa?
To rule out whether this patient having asthma or not.
Okay. So okay lah.
Post bronchodilator.
Itu boleh, tapi macam tak appropriate. So your first diagnosis is pneumonia. So you kena investigate regarding pneumonia first lah.
Alright.
For apa pneumonia you nak investigate tu based on apa?
Sputum culture.
Okay lah, sebelum sputum lah, selalunya kita akan sebut blood dululah.
Blood dulu.
So in the blood, what do you expect to see or to find in the blood?
For the
blood tu pun you nak tahu for what?
Full blood count. We order for full blood count. We look
Okay.
for evidence of infections such as increase in total white blood cell count, and also the specifically neutrophil count.
Okay.
It might indicate of bacterial infection.
Okay, good. So kita mention terus lah. So jangan mention just ABC. ABC untuk apa? You kena mention to look for total white count, raise in total white count. That's suggestive of infection. So if bacteria, neutrophilia will be higher lah compared to lymphocyte. So tapi but not necessary lah now. Tapi we still use neutrophil and lymphocyte as indicator to differentiate between bacteria or virus infection. So other than that, other than total white count, what do you want to see?
The HB.
Okay.
For anemia.
Okay. Why?
Because patient ada SOB. So
Okay, good.
macam nak rule out anemia.
Yes. Sometimes we don't know, right? Ini pneumonia ke? Sometimes patient dah dapat anemia symptom lah. Anemia symptom. And satu lagi kita tengok HB, sometimes patient patient tu come to with severe sepsis. So HB will be affected lah because dah severe sepsis, mungkin dah lama kat rumah ke dah jadi kronik. HB tu akan affected. And then selain daripada tu, HB total white count selalunya apa? 3 benda yang selalu doktor tulis.
Sputum culture.
Daripada FBC.
Oh, FBC.
HB, total white count, satu lagi platelet.
Platelet.
So platelet pun indicating juga. Low platelet, high platelet, thrombocytopenia, thrombocytosis also indicate patient have infection. Okay, so lagi selain daripada FBC, blood dulu.
Blood urea serum electrolyte.
Arti
Metabolic imbalance.
Okay, ini electrolyte bukan metabolic.
Electrolyte.
Electrolyte imbalance. Okay, kenapa? Why? What? Is there any relation between RP and patient with pneumonia?
Usually patient with pneumonia have hyponatremia.
Okay, why? Apa condition kita mention?
SIADH.
Okay, good. So SIADH. Okay, so that's why this will affect your management lah. Kan? Nanti saya tanya management, kenapa dia affect management? In what way? Okay, so patient with pneumonia boleh dapat SIADH. So SIADH dia dah boleh dapat hyponatremia lah. So hyponatremia. So that's why we need to check the RP. And sometimes we also we need to send for LFT to look for any transaminitis. Sometimes memang pneumonia, but severe pneumonia came with sepsis. So patient we have transaminitis. So basically you need to check all lah, RP, LFT. Okay, so lagi you kata pasal sputum, right? Sputum pun dihantar. Soalnya depends. In real world, you tak akan dapat hantar semualah sputum. Unless dia very chesty, throat sangat. Soalnya kita akan ambil swab, nasopharyngeal, aspirate. Sputum culture tu kalau dia boleh expectorate lah 6 years old mungkin boleh pandai ajar. Dia boleh hantar sputum for culture. Orang tua memang kita hantar lah sputum CNS, sputum culture. Kalau tak kita akan aspirate using NPA. So and then daripada selain blood tu chest x-ray to look for the evidence of pneumonia. Whether it's bronchopneumonia, lobar pneumonia. Bronchopneumonia pun dia ada description dia, consolidation, collapse consolidation, evidence of air bronchogram, prominent bradycardial haziness, bradycardial streakiness. So tu itu pun dia ada ni lah. So basically kalau pneumonia, you look for the air bronchogram. Ataupun you look for sign of consolidation lah. Kalau consolidation senang lah, you nampak stepek putih. And then usually dia ada air bronchogram. So itu kita punya description untuk pneumonia lah. That is evidence of consolidation with air bronchogram over the right upper ke middle ke lower zone. Kita mention tu based on dia punya location lah. Loop location, right? Bukan loop location. But loop location. Lung location lah. Manalah upper, middle, lower kita sebut lah. Sebab lain kan, right dengan left. Left ada 2, right ada 3 loops. So upper, middle, lower. So and then daripada X-ray tu you kena mention lah, is it trachea tu centrally located ke, ada pleural effusion, planted costophrenic angle. So banyaklah you kena mention X-ray tu. So even X-ray pun dia ada cara dia nak present. Kan, you not simply say oh patient no haziness. Basically you kena tengok daripada awal lah.
Nama,
itu nama lah. So nama you just mention lah. This X-ray belong to adik Muhammad Azham, 3 years old, was taken today, and chest X-ray is in AP position. AP position. So tengoklah, sometimes tu tengah orang dia akan define ataupun describe in to out. Ada yang out to in. You nak mention pasal lung dulu pun boleh, and then later on you keluarkan lah Maksudnya kena mention sampai bone, sampai muscle. Trachea macam mana, rush tube kat mana, diaphragm ada ke tak, centrally okay ke tak, diaphragm tu elevated ke tak, posterior lung inflation berapa, posterior rib berapa, nak mention dia hyperinflated ke not hyperinflated, semua tu ada description dia. So investigation, lepas investigation, management. So how do you manage this patient?
So for management, for this patient, first I would like to maintain the SpO2 more than 95% and give oxygen, and then start antibiotics.
Okay.
Augmentin.
Okay. Why augmentin?
Apa what?
Why augmentin?
Broad spectrum, nak cover for gram positive.
Nak cover for?
What spectrum punya antibiotics, cover for gram positive negative.
Okay. Tapi bukan white cover lah. Sebab pneumonia augmentin tu dia contain apa?
Clavulanic dengan
Amoxicillin.
amoxicillin.
So dia combination lah. Combination amoxicillin tu beta-lactam antibiotic, beta-lactamase, and potassium clavulanic pun beta-lactamase inhibitor. So dia combine lah. So basically antibiotic ni based on age group. Different age group, different antibiotic lah. So younger age group macam less than 3 months old, the most common cause is apa?
Less than 3 months old, usually group B streptococcus,
Yes.
E. coli, Klebsiella.
Okay, so after 3 months old, macam infant lah. Itu dah tadi dah infant kan. Toddler.
Kalau toddler selalu streptococcus pneumoniae, Haemophilus, influenza B dengan Staphylococcus.
Dia strep, Haemophilus dengan influenza lah. Kalau atas sikit, lepas dah infant, toddler, children lah kan.
Children.
Ataupun school age group. So school age group dia ada apa tambahan?
Chlamydia dengan mycoplasma.
That's why you tengok different kat ward tu, not all patient ada. Sometimes tu ada augmentin, kenapa ni ada ES, kenapa ni ada azithro. Tapi basically augmentin tu dah cover lah. Augmentin is not a broad spectrum lah. Dia bukan broad spectrum lah. Tapi dia most common organism yang found at the age group and our community, we cover with augmentin first. Usually we use amoxi. But amoxi is macam less effective. Augmentin ni macam upgrade version of amoxi lah. Sebab ada clavulanic acid. So the broad spectrum, selalunya kalau you nak tengok, kita akan guna cephalosporin. Broad spectrum cephalosporin third generation. And sometimes you pernah tengok patient bagi cefuroxime ke, cefotaxime ke, dosofin ke, itu broad spectrum. Selalunya kita akan guna tu second line lah. After augmentin tak jalan, patient still demam, kita upgrade tu cefuroxime. Cefuroxime tak jadi, kita upgrade tazocine, piptazo. So different. So bear in mind, not all antibiotic lah. You need to based on patient age group and what the organism. So that's why all the age group kita bagi, kalau atypical infection kita cover for mycoplasma, ES or azithromycin. So for the management, to make it easy and to gather your thought tu, you susun according to ABCD lah. ABCD maksudnya airway. Okay, airway breathing selalunya sekali lah. Cuma kalau breathing tu, kalau patient ventilated dia lain lah. So kalau you put on airway, breathing, circulation ke drug. So kalau airway dulu, you tengok patient apa, nesoprong. So I would like to put patient on nesoprong 1 liter per minute. So dalam airway, breathing samalah. Mungkin you boleh you letak airway breathing tu sekali lah. So first penting sekali, you janganlah letak first tu you punya apa plan you. Kalau orang tengok pun kita tengok by susunan kan. Nombor satu selalu orang akan anggap benda tu paling penting lah kan. So kalau dia letak susunan nombor satu, encourage orally, patient pneumonia on nasoprong, take it ni, your plan encourage orally. Macam okay, itu paling penting, macam pelik lah kan. Tak pun dia kata patient take it ni tepid sponging, macam pelik lah. So put yang paling utama airway, sebab airway even kat mana-mana pun, even emergency pun kita pun sama tengok airway, breathing, circulation. So put airway first dulu. So nasoprong, after nasoprong A, B, C, circulation ni tengoklah you nak put patient NBM ataupun you boleh lah, okay lah nak find encourage orderly. Kalau you rasa patient take ni, okay, I would like to NBM first, and then put patient on IV drip. So IV drip tu tengoklah you nak bagi apa, half saline D5, 1/5 normal saline D5, and then how much. So kalau in this patient, kalau patient NBM, so how do you give the fluid? How do you calculate? Based on what?
Intravenously.
Okay, obviously intravenously.
Based on the tuning.
Kalau you belek-belek tu kan dia orang tulis kan berapa mil per hour tu, dia orang based on apa? Macam mana dia orang calculate?
Input output.
No. Kan you pernah buka kan, you buka BST, you tengok plan. Okay, so keep patient NBN, put on IV drip, 1/5 normal saline, half saline ataupun normal saline D5. D5 tu that's 5% lah. Normal saline D5, and then dia calculate, okay, 20 mil per hour dalam bracket full maintenance. Semuanya macam mana dia dapat tu?
Ya, ni maintenance yang formula Sega, Holiday Sega.
Yes, it is based on Holiday Sega. More than 1 years old guna Holiday Sega lah. So the weight, dia depends on the weight of the patient. First 10 kilo dia time 100 mil. Second 10 kilo dia time 50 mil. And the rest 10 kilo tu dia times 20 mil. So kalau budak 20 kilo, dia dah jadi 1,500 mil dah. So that's requirement untuk that baby lah. So bila kita kata full maintenance, 1,500 lah. So kalau 2/3, macam patient ni selalunya IVD dia tu kita bagi berapa banyak? Kita bagi full ke, half ke, 2/3?
Kalau patient
Dia ada perasan tak? Dia ada perasan kalau budak-budak ni tulis, SO tulis specialist round ke, dia tak bagi pun full maintenance, dia bagi 2/3 je. Sebab macam you mention lah, sebab dia pneumonia ada kaitan dengan SIDH. So in SIDH, walaupun dia hyponatremia, you cannot give more fluid. Sebab dia akan retain water. Retain water, patient dah edematous. So edematous worsen, dia punya lung become more wet. That's why kita reducekan fluid dia to 2/3 maintenance. That's why dia 2/3 maintenance. So 2/3 maintenance, you kena kira based on Holiday Sega. And then the third one, you dah go nasoprong, dah MBM kan dia. So drug lah. Drug apa? Okay, baru dah letak start antibiotic, IV Augmentin, 25 mg per kilo TDS. Ataupun okay nak add sirap ES tu depends lah. So drug. Pas drug tu, you letak lah monitoring yang lain. Maksudnya, okay, keep SpO2 more than 95. Yang lain-lain lah, macam panjang tu keep SpO2 more than 95. Watch out for respiratory distress, monitor temperature, monitor IO chart. Yang monitor tu boleh letak kat bawah. So okay lah, gitulah pneumonia. Ada apa nak tanya? Gelap dah kat sini. Ada soalan ke? Yang lain, siapa ada ni? Ali, Afifah, Murad, Nafis. Siapa lagi? Afaf ah. Nurisham, Hidayah. Any question?
Doctor, I have one question. How to macam differentiate between typical and atypical pneumonia? Macam presentation patient tu sama macam typical, macam came with SOB, cough,
Okay.
and tapi dalam HBHV tulis atypical pneumonia.
Okay. So sometimes depends on kalau if depends on the physician lah. So typical or atypical itu kalau typical, how do you diagnose pneumonia? Kalau based on definition, how do you say this patient have pneumonia?
Cough, fever,
Okay.
rapid breathing.
So patient with pneumonia kena ada rapid breathing and fever lah. So to differentiate broncho dengan lobar based on chest X-ray, right? So that one kita panggil typical pneumonia. Tapi kita tak tulislah kat situ typical bronchopneumonia, kita tak katalah. Sebab dia memang patient datang fever and then respiratory symptom and then tachypnea. So kita kata dia pneumonia. So kalau atypical pneumonia ni setengahnya I tak tahulah based on book ke based on real definition pun I pun tak Google out. Tapi I pun tak tahu dia ada tulis ke atypical ni. Sebab maksud atypical adalah dia bukan typical lah. Kan? Obviously. So kalau you nak kata patient atypical, okay, for example, one patient datang dengan cough runny nose and tachypnea. So we know it's pneumonia. From physical examination, you find it's capitation. Kan? You dengar capitation, right? Hello?
Ya, doktor.
So you dengar capitation. So dia still typical kan? Tapi however the chest X-ray, normal chest X-ray. So that's when we call it atypical pneumonia. Sebab tak tally. So we expect to see the X-ray, ada X-ray finding. Ataupun satu lagi condition, the other way round. Patient okay, just ada cough, tak tachypnea, lung clear, tapi chest X-ray bad.
Positif.
Chest X-ray bad. So kita kata atypical pneumonia. So mana-mana maksudnya dia bila typical, atypical tu the other way round lah. Dia opposite the typical lah. Kalau typical fulfill all the criteria lah. Daripada history, physical and finding. X-ray, finding. Atypical, sometimes tu normal kita tengok patient, tak tachypnea pun patient ni ada cough runny nose tapi X-ray lobar pneumonia. Dia mungkin ada pneumonia juga tapi kita cover for atypical, boleh datang macam tu. And then satu lagi atypical ni macam most common mycoplasma, mungkin dia ada, kita panggil dia ada atypical features yang lain lah, like ada rash, dia ada conjunctivitis, dia ada eye discharge, ear discharge, boleh datang dengan atypical. So itu kita bila kita kata atypical lah. Tapi tengoklah atypical ni selalunya most common mycoplasma. So age group tu 4 ke 5-6 years old tu baru kita kata atypical lah. Jarang lah you jumpa berumur 5 bulan kita kata dia atypical pneumonia sebab tak tally. Possible tu ada tapi tak tally lah, pelik lah orang akan pelik lah. Okay. Itu menjawab soalan tu, tak menjawab soalan tu?
Menjawab, doktor. Thank you.
Okay. So ada apa lagi? You rasa membantu ke?
Apa dia?
Our session. I tak tahu sebab I tak pandai nak ajar orang.
Bantu?
But I tak tahu previous lecturer tu macam mana. Sebab suppose your lecturer tu ialah siapa Alwi Alwi dengan Datuk
Datuk, Dr. Syed.
Dr. Syed. Mungkin different style tapi diorang sama je datang. Alwi USM, Dr. Syed pun daripada USM kan. Datuk pernah kerja dekat HTAA. Dia my boss lah during my HO, MO. So tapi basically undergrad macam tu lah. So kurangkan bercerita lah. Kalau you tanya parents memang dia akan bercerita kan. Tapi kita kena gather our thought, susun elok-elok dan kita present. So jadi komplain ya. Bagaimana kan I ambil kelas sebelum ni pun cara yang sama. I tak tahu itu memang macam tu ke cara yang sama juga dia orang present. Macam you all present lah. So tak tahulah, I takut you all akan keliru ni doktor ni cakap macam ni. Doktor tu cakap macam ni. You rasa ada beza ke? Alwi, Datuk, Dr. Syed dengan siapa? Ajar.
Sepanjang kita orang undergrad ni banyak doktor, banyak cara juga. Ada yang nak kronologi, lepas ada yang macam bagi tahu simptom tu. Ikut mana yang present dulu apa semua. Lepas tu sampai yang dia masuk hospital.
Macam yang aku cakap lah. So lepas tu yang mana yang betul? Yang mana
Tak tahu lah.
You nak bawa untuk exam nanti?
Kena ikut. Kalau nampak lecturer tu, okay, buat cara lecturer ni. Situ.
Tapi bagi aku, you boleh combine. Kalau lecturer tu, okay, you nak buat present macam tu, you combine lah chronological dengan maksudnya you put all, you list all the presenting complaint and then you describe. Sebab sometimes tu jarang patient datang fever dulu and then after 2 days cough. Sometimes tu they come together. That's why we need to mention together lah. Cuma kita mention tu sebab each symptom you need to elaborate kan. Kena elaborate. Then barulah you beritahu chronological macam mana. Supaya orang akan senang lah. Kalau macam jumping, dia dah anti climax tau. Dah course SOB, dah pergi hospital dah. Settle lah, tak present apa lagi. So, kena present apa yang patient ada. Bagi akulah, itu lagi orang akan more clear. More interesting. Sebab, bezalah. Kalau postgrad orang tak nak dengar dah. Cerita 3 hari tu, dia tak nak dengar dah. Dia nak tahu apa diagnosis you. Dia nak tahu terus. You dah ada pneumonia ke, you dah diagnose dia bronchial asthma ke, dia nak tahu. And then, dia nak tahu kenapa you kata bronchial asthma. Itu je, dia tak nak dah dengar 3 hari, 4 hari tu. Tapi tak apalah. You tengoklah yang mana you rasa okey. Tapi kalau boleh gabung, cuba gabung lah. Bagi aku, the type presentation tu dah okey. Cuma cara nak arrange je. Benda tu dah ada sebenarnya kalau you all tengok kan. Cuma nak arrange je, nak letak atas ke bawah ke tengah, itu je. Itulah. Okay. Semua muka dah tak nak tengok dah. So is there any question? Murad, are you okay, Murad?
Yes, I'm fine.
So Murad, where are you from?
Originally from Libya.
Libya, okay. Not originally?
I've lived more than half of my life in KL.
Oh, so you basically Malaysian lah?
No. I don't classify. Yes, Libyan.
Okay. So how? Okay, any more question? Ke Afifah nak present lagi?
Ayah tu dah.
Lah. So we end our session lah. Okay. If there is no more question, so we end our session lah. So I hope this session benefit to all of you lah.
Alright, Doctor. So we end our session with Tasbih Kafar and Surah Wal-Asr.
Okay, Alhamdulillah. La ilaha illa. Wala ansika Bismillahirrahmanirrahim. Amanu wa amilus salihati wa tawassaw. Bagus.
Yeah. Okay. Thank you very much, Doctor.
Thank you.
Thank you very much, Dr.
Thank you, Doctor.
Thank you.